Hello everyone, I'm Dr. Benita from SRM Medical College, and today we are going to talk about the IAP standard guidelines for acute bacterial meningitis. Acute bacterial meningitis is one of the most common causes for morbidity and mortality, with deaths of over 180,000 globally. It occurs mostly in the age group of 1 month to 5 years. And when there are risk factors such as poor socioeconomic condition, recent colonization with the bacteria, or close contact with a person having an invasive disease or overcrowding. Other conditions, such as if the child has a splenic dysfunction, or if the child is immunocompromised, or if there is a CSF leak, or if the child had a cochlear implant, all of these pose risk factors for developing acute bacterial meningitis. Now, what are the causative organisms? It depends on the age group. In neonates, it mostly ranges in the gram-negative spectrum, starting from E. coli to Klebsiella pneumoniae. And in the late onset, we have Staphylococcus aureus, Enterobacter salmonella. Now, 1 to 3 months, it gives a mixed picture with gram-negative as well as gram-positive. Gram-negative, we have E. coli, Klebsiella pneumoniae, and the main 3 gram-positive, we have Streptococcus pneumoniae, Neisseria meningitis, and Haemophilus influenzae B. Now, 3 months to 5 years, it's the same 3. But more than 5 years, we do not have Haemophilus influenzae. It's only Streptococcus pneumoniae and Neisseria meningitis. Other than this, there are certain predisposing factors and specific organisms cause it. CSF leak, we have Streptococcus pneumoniae. If there is a CSF shunt or meningomyelocele, we have Staphylococcus aureus or Staph epidermidis. If the child has a splenic dysfunction, for example, due to nephrotic syndrome or sickle cell anemia, then the 3, Streptococcus pneumoniae, Neisseria meningitis, and Haemophilus influenzae. If there are defects in the complement system, then Neisseria meningitis is the cause. And if there are T cell defects, then Listeria monocytogenes is the cause. Now, since it has a high morbidity and mortality, we need to have high level of suspicion for early diagnosis. So how does the child present with? In neonates, the presentation is different, and in older children, it's different. In neonates, the symptoms are very subtle. So there's lethargy, refusal to feed, irritability, incessant cry, and the child can present with seizure and altered mental status. And there will be a persistent bulging fontanelle. In older children, the presentation can be hyperacute or acute. Hyperacute is less common, which occurs in the first 1 or 2 days, and the child present with sudden rapid onset of fever leading to shock and DIC. In acute presentation, 2 to 7 days it presents, and there are non-specific systemic findings such as fever, vomiting, headache, and upper respiratory tract infection. Along with these, there are signs of meningeal irritation, mucal rigidity, that is neck stiffness, and positive Kernig's and positive Brudzinski sign. Children less than 18 months old, we do not see the next signs. Raised ICP, how do we find in a child? The child will present with headache, MSS, that's vomiting, bulging anterofontanelle, diastasis of sutures, and 2 nerves, oculomotor and abducens nerve paralysis. Along with this, hypertension and bradycardia, apnea or hyperventilation, that is the Cushing's reflex, can also be seen. Now, when do we not see this nuchal rigidity? It is absent in infants, or if the child is severely malnourished, or if the child is terminally ill, or if the meningitis was partially treated. Meningismus, which is false positive nuchal rigidity, can be seen in typhoid and retropharyngeal abscess. Now, how do we diagnose? Lab investigations, there are mainly 3 things: blood tests and CSF fluid analysis. In blood test, culture, cell count, C-reactive protein, and procalcitonin needs to be done. CSF fluid analysis, we should do everything ranging from biochemistry to cell count to glucose to proteins. Now, when is lumbar puncture contraindicated? Lumbar puncture is contraindicated when there are signs of raised ICP, which I already told, and when there is local skin infection, or if there is obstructive hydrocephalus or cerebral edema. Now, the normal CSF fluid parameters in a child, the CSF pressure should be less than 28 mmHg, the cells should be less than 6 cells, and there should be no neutrophils, and proteins can range from 20 to 45 mg per dl, and sugars more than 50 mg per dl. Now, how do we differentiate it? differentiate based on the results from CSF fluid analysis. First, we'll see bacteria. The cell count will be 10 to 100 to more than 1000. But the predominant cell type will be neutrophils in bacterial cause. And proteins will be slightly elevated, 50 to 100 or to more than 500, but the glucose will be reduced. Whereas in viral cause, the cell count can be normal or it can be up to 100, but it is lymphocyte predominant, and proteins can be normal and glucose can be slightly reduced. Now, Mycobacterium, the difference is that it is predominantly lymphocytic, even though it's a bacteria. And the cell count can be 10 to 500, and proteins can be normal or a little higher. Glucose will be reduced. Fungal cause, it gives us a mixed picture. So it can be neutrophilic or lymphocytic. And cells can be normal to 100, or proteins, glucose can also be normal or slightly elevated. Next, how do we approach this case? So first, we clinically suspect, and then we evaluate if the child is in any hyperacute state, such as shock, or if the airway breathing is fine, or if there is any neurological deficit. Then we check if CSF study is safe, that is, if lumbar puncture can be done. If the contraindications are ruled out, then we do lumbar puncture, and then we can consider brain imaging, and we start antibiotics. If lumbar puncture cannot be done, we start empirical antibiotics. And later on, if still there's no improvement, we reassess the clinical findings, imaging data, and continue the same therapy. Now, when should we do brain imaging? Before lumbar puncture. That is, if the child has a status epilepticus or a focal neurological deficit, or if the GCS is less than 12, then we should do brain imaging. Or if you see signs of raised ICP, we have to do brain imaging. Signs of complicated meningitis, such as subdural empyema or focal cerebritis or an evolving abscess or ventriculitis. In all of these conditions also, brain imaging, that is CT and MRI, is advised. Meningeal enhancement, that is contrast enhancement, will be seen. And MRI is more desirable than CT. So how do we start antibiotics? It should be started empirically as soon as possible. And to reduce the inflammation, before starting antibiotics or within 4 hours of starting antibiotics, we can give corticosteroids. So how long do we continue therapy? Streptococcus pneumoniae is the most common. So for Streptococcus pneumoniae and unspecified bacterial meningitis, 10 to 14 days, we continue antibiotic therapy. Now, what antibiotic therapy do we give for what age group? It is given intravenously. If the child is less than 1 month, we start with ampicillin and cefotaxime, or ampicillin plus an aminoglycoside, such as amikacin or gentamicin. Now, we give ampicillin to also cover Listeria monocytogenes, which is a causative organism for less than 1 month. Now, 1 month to 24 months or till 18 years, we treat with vancomycin and a third generation cephalosporin, commonly ceftriaxone. This is to cover all of the main groups. Now, there are special conditions such as head trauma or post-neurosurgery or CSF shunt. Now, if these are the causes for acute bacterial meningitis, then we treat with vancomycin plus cefepime or vancomycin plus ceftazidime. This is given so that we also cover Pseudomonas and staph. If subdural empyema or ventriculitis is the cause, then we'll have to go for a neurosurgical consultation, and burr hole or craniotomy can be done. With this, we finish the IAP guidelines for acute bacterial meningitis. Thank you.